Kumardeep Paul, on behalf of the medical team at BI, would like to welcome you all to a very interesting session today. Our topic today resonates with certain interesting insights on management of stroke or cerebrovascular diseases. As we understand, stroke is a major cause of morbidity and mortality in India, and the prevalence is rising as we speak. In fact, certain scientific discussions mention that there could be probably around one stroke event occurring in India every 20 to 40 seconds. An important cause of stroke is atherosclerosis of the extracranial and intracranial arteries supplying the brain. Atherosclerotic stenosis can also be asymptomatic, and patients may be identified during investigations for other comorbidities. But the challenge arises when faced with a decision on how to treat patients with symptomatic and asymptomatic stenosis, whether extracranial or intracranial. There is another disease which shares common risk factors with cerebrovascular diseases like hypertension, history of smoking, etc., which is unruptured intracranial aneurysms, the treatment of which, again, is very challenging. To share with us their expert opinion on both the topics, we would like to welcome an expert panel from the field of neurology and interventional neurology. In order of their talks, we would like to welcome Dr. Raj Srinivas Parthasarathy, Head of Stroke Unit and Senior Consultant of Neurointervention at Artemis Hospitals, Gurugram. And we also welcome Dr. Vipul Gupta, who is the Chief Neurointerventional Surgery and Co-Chief of Stroke Unit at Artemis Hospitals, Gurugram. So it is indeed an honor to welcome both our panelists to today's session. Before we begin, an earnest request to all our participating doctors to kindly put in your queries or your questions and even your opinions in the chat box, and we shall take them right at the end of the primary set of talks. So without much further ado, I would like to welcome and request Dr. Parthasarathy sir to kindly share his thoughts on the first topic, which is intra and extracranial arterial stenosis and its management.
Kumardeep, are we recording?
So this will get recorded on the platform, sir.
So I'd like to thank BI for this opportunity, and I'd like to thank all the attendees also to take time out to attend this session. So today we will discuss predominantly intracranial atherosclerotic disease. And really my aim is to throw some insight into some fluid dynamics, how physics plays a huge role when deciding how to manage these set of patients. Okay. So what will we be discussing? So whenever you have intracranial atherosclerotic disease, and we decide to manage the set of patients, initially we try medical management, and then if it is not responding to best medical therapy, we go ahead with stenting. So to decide on the risks with revascularization of that artery, we need to think about what is the risk of side branch occlusion, what is the probability of in-stent restenosis, what are the causes and the management. Whenever you have intracranial atherosclerotic disease with acute occlusion, what will your management strategy, and some of the complications that we had encountered. So the first case and the first theme would be the risk of side branch occlusion. Let's look at this case. This is a 65-year-old male who had recurrent symptoms, 2 episodes while on dual antiplatelet therapy. There is a mid-basilar tight stenosis. And the question you need to know is, the question you need to answer is, what is the risk of stenting in this particular patient? If you see here in the 3D angiography, there looks to be some stenosis of the origin of the right anterior inferior cerebral artery. So the first question is, which wall of the artery is involved with the plaque? For example, in the basilar arteries, the ventral, dorsal, or the lateral walls. And what is the side branch involvement? How much is the ostial stenosis? So if you look at the AP projection here, you clearly see that the plaque is in the right lateral wall of the artery. And if you see the sagittal projection, the plaque is in the anterior wall. So there's an interesting paper that has been published which says that in the basilar artery, the ventral wall has a greater plaque surface area and greater plaque fraction percentage. And the posterior circulation arteries are known to have positive remodeling as compared to negative remodeling, which is more common in the anterior circulation arteries. And they thought that it was because of low wall shear stress. And this low wall shear stress is due to the lack of sympathetics in the posterior circulation. So now we have decided which wall the plaque is. We said it is the right lateral wall and the anterior wall. Now we have to decide what is the risk of the side branch occluding. So this is the 2D angiography. And if you go in for a zoomed in view, you see that the plaque is in this right lateral wall, and clearly there is some ostial involvement. And we need to categorize as to what is the extent of stenosis of this ostium. So there's an interesting paper that is published in cardiac literature, which looks at the side branch occlusion risk. So these two configurations here are threatened morphologies. So what does a threatened morphology mean? Here you have a plaque that goes across the ostium, but it causes ostial narrowing by more than 50%. Here there's a plaque reaching up to the ostium and again causing a stenosis of more than 50%. And this category causes a high risk of side branch occlusion. Whereas all other configurations are classified as non-threatened morphology. In this particular paper, there was a side branch occlusion rate of 20%, and the key predictors were a threatened morphology, i.e. 1A and 1B, plaque ulceration, and high pressure post-stent dilatation, wherein you snowplow this plaque into the ostial orifice of the perforator. Look at this here. If you have a threatened morphology, there's an 80% risk of side branch occlusion as opposed to less than 5% if there's a non-threatened morphology. So this is something you need to look out for to decide what is the risk of side branch occlusion. So here, I would say that this would fall at 2D, meaning there is a plaque there, but it is not causing more than 50% ostial stenosis of the right anterior inferior cerebral artery. So therefore, it is safe to proceed with stenting in this particular patient. So this is the guide catheter here. We tend to use a stiff wire. Here we are using a coronary wire, but the tip is very soft. And this is the balloon angioplasty. Post angioplasty, we were a little worried as to what's happening to this anterior inferior cerebral artery origin. We went on to deploy a drug-eluting stent. Again, we'll discuss about drug-eluting stent in great detail in the rest of the lecture here. And if you see here, there is good antegrade flow post-stenting in the right anterior inferior cerebral artery. This is expert CT angiography. Although we saw that there was good flow, careful look at this picture shows there is some ostial stenosis, which is probably worse than what it was at the initial angiographic picture. However, there was good antegrade flow. Patient did extremely well. Whereas other arteries where there were no ostial stenosis, they looked completely well preserved. So then the question comes on to which wall of the artery is more commonly involved when there is a side branch arising. And the answer is again from the coronary literature. Imagine this to be the left main coronary. This is the left anterior descending, and this is the left circumflex artery. They found that the plaque tends to arise opposite to the wall of the side branch, which is really good for us because if the plaque is going to be on this wall, then there is a higher risk of side branch occlusion. Further studies from coronary literature again, this is an intravascular ultrasound, which shows the location of the plaque in relation to the side branch origin. In this particular instance, there is an origin of the side branch which is at 90 degrees to the artery, and they found that the plaque was more common in the wall opposite to the origin of the artery. When there is an angle takeoff, here there is a clockwise angle takeoff. There is more plaque that forms on the wall ipsilateral to the acute angle. And when there is an anti-clockwise takeoff, there's more plaque forming on the side ipsilateral to the acute angle. Let's go through two other examples to assess the risk of side branch occlusion. So this is a 65-year-old male quadriparetic. This is an acute setting, 6 hours from onset. MRI was not working. If you see there's a pencil tip occlusion of the basilar artery, the basilar tip is perfused from collaterals. So we think that this could be intracranial atherosclerotic disease. This is the initial angiographic run, which shows this an occlusion of the mid basilar. Post stent retriever deployment, there's some sheets of clot here. We give GP2B3A antagonist, and then we deploy, let the stent be in place for nearly 15 minutes or so, and then we retrieve the stent. And this is quite good looking, clean artery here with the residual stenosis, which is significant, but even after 50 minutes, it remained the same. So here the strategy was stent plus to the GP2B3A antagonist. So what is the so how do we decide in this particular patient, do I go ahead for stenting or not? One of the things that you need to look out for is the lateral wall involvement, because we know that this is the wall which is perforator rich. In this particular patient, we did not go for stenting. And the reasons behind that are, we know that the plaque was in the right lateral wall and as well as the anterior wall. There was thrombus. It's an acute fresh plaque. The lateral wall is perforator rich. The artery was remaining stable up to 50 minutes. And we did an expert CT before any loading and putting a stent. And there was a bit enhancement in the infarcted areas. So that is why we did not go for stent here. And this is the post-procedure MRI, which shows right pontomedullary junction infarct, and there's a left pons infarct as well. Patient did extremely well. So what happens in the interim follow-up? So this is a follow-up angiography, which is done a few weeks later. If you see here at the side branches more carefully, these are the side branches that are originating from the basilar artery. There is significant osteal disease, even if this artery is quite significantly involved. So this would classify as a 1A, wherein there is atherosclerosis of the main artery, but the ostium is involved, and there's nearly more than 50% occlusion of the ostium. So this is generally a high risk for side branch occlusion, and therefore we did not prefer stenting in this particular patient. This is a case 30-year-old male with deep infarct. If you see, this is the 3D rotational angiography. There is some narrowing of the distal middle cerebral artery. This is a cranial caudal view, which again shows this narrowing here. And there's a deep infarct. This is the expert CT angiography, where we look for these perforator. We know this is a perforator stroke. There's a lateral ventricular artery which is involved. And if you see here, the origin of the artery, there's a very tight stenosis, literally arising from the plaque area. So if you stent this artery, we are almost certain that this side branch is going to occlude, and therefore we would not consider stenting in this particular case. Again, a 1A morphology, plaque involving the ostium with osteostenosis more than 50%. So that is the first theme of the talk. What is the risk of side branch occlusion? The second theme of the talk is what is the risk of in-stent restenosis? This is from the Sampras trial, which said that there's a 10 to 14% risk of in-stent restenosis from 1 to 3 years following stenting. And they found that of all strokes TIA beyond the 30-day period, 70% were attributable to in-stent restenosis. So a quick example, a very old case, right hemispheric stroke, right supraclinoid SC stenosis, balloon angioplasty stenting performed. 3 months later comes in with a stroke, recurrent stenosis, repeat angioplasty, again another stroke, again you see stenosis and an angioplasty is performed. So we know now that in-stent restenosis is particularly common in the supraclinoid SCA and particularly with the self-expanding stents. So what are the important lessons that I have learned and probably I could share with you with regarding to in-stent restenosis? The first rule is endothelial shear stress plays a key role with regards to in-stent restenosis. There are two types of stress on the wall of the artery. One is the normal stress, that is the pressure exerted on the wall of the artery. And this pressure is perpendicular to the wall of the artery. So this is the wall of the artery, and this is the perpendicular stress. The other one is tangential, or the stress that is parallel to the wall of the artery, and this is called as shear stress. So the key message is low shear stress is the main culprit, not high shear stress. Whenever there is a low velocity flow, that equates to low endothelial shear stress. So let's look at what are the sites of low endothelial shear stress. This is a common carotid artery bifurcation. This is the pattern of flow into the internal carotid artery, and this is the external carotid artery. So there is a flow divider here. So whenever the flow goes from the common carotid to the internal carotid artery, or into the external carotid artery, there are what is called as separation zones. And these are low velocity flow zones. And usually the flow is separated from this area because there is a divergent wall. And flow from the divider goes circumferentially and reaches the zone, and then there is an antegrade flow. So this is a low velocity flow. Therefore, there's a low wall shear stress, and therefore generally plaque forms on these walls. Another example, this is an intracranial artery. There is an atherosclerotic plaque. Flow is in this direction. What we know is beyond the plaque, there is low velocity flow, low shear stress. And this area has low endothelial shear stress. We see a lot of patients who do not have any risk factors at all. So therefore, just not atherosclerotic risk factors which predispose to atherosclerosis. Even the curvature of the artery can predispose to atherosclerosis. If you take a very curvy artery here, and this is the direction of flow, we know there is low velocity flow on this wall and a high velocity jet on this wall. And therefore, there is low endothelial shear stress or wall shear stress in this area. And this is area which is prone for atherosclerosis. This is the case after stenting as well. If you see here, there is a strut here, and beyond the strut, there is low velocity flow, oscillatory shear, and low endothelial shear stress, which promotes neointimal hyperplasia as well as neoatherosclerosis. So what does low and high shear stress do? Wall shear stress, when it's low, it triggers TNF and interleukin 1B, and this triggers high-risk blast features and a positively remodeled plaque. It also initiates neointimal hyperplasia and neoatherosclerosis. Whereas, to the contrary, high shear stress inhibits TNF and interleukin 1B. There is a stable plaque without progression, and this causes activation of platelets, and therefore thrombosis is more common. Now, having discussed this, the stent we deploy plays a key role in the risk of in-stent restenosis. So we have the bare metal group as well as the drug-coated group. And then we need to discuss which drug is better. Is paclitaxel better, or the limus-based sirolimus, everolimus drugs are better? What is the geometry of strut? And does it play a role? Small stents, long stents, and overlapping stents. So we know that the rate of in-stent restenosis is less with drug-eluting stents. Why? Beyond every strut, there is low velocity flow, there is low shear stress, and whatever drug is eluting from that particular strut, there is a higher residence in this area beyond the strut, and therefore this inhibits neointimal hyperplasia and inhibits smooth muscle cell proliferation, and therefore is an advantage with drug-eluting stents. Which drug is better? We know for sure that sirolimus, everolimus group of drugs are better than paclitaxel group of drugs, because low ESS causes smooth muscle cell proliferation, and this limus-based drugs inhibits the smooth muscle proliferation and inhibits this pathway. Whereas paclitaxel does not inhibit this particular pathway, and in fact, it enhances secretive smooth muscle cells, and therefore is not a good option now. Now, let us look at the geometry of the strut. There are two geometries which I've given. This is a big strut with rectangular configuration. This is a semicircular strut with with a small, less thickness. So, people have moved from this strut configuration to this configuration. So they want a very thin strut as possible. Second, they have moved from a rectangular configuration to a semicircular configuration. So the luminal surface has to have a circular configuration. Third, they also looked at what is the breadth to height ratio. Here you see the breadth is 8:1, meaning there's much bigger breadth than the height. And the last one would be, you want there to be more distance between one strut to the next strut. If you have a much bigger distance, this allows for the ESS to recover, and therefore the risk of neointimal hyperplasia and neoatherosclerosis is less. So this is a non-streamlined strut, and this is a very streamlined strut. If you see here, there is significantly low endothelial shear stress, oscillatory shear here, and this will promote NIH and neoatherosclerosis, neointimal hyperplasia and atherosclerosis. Whereas this wall shear stress is not that low in this particular strut configuration. Now let's look at the strut thickness comparison. So we know this reabsorbable stent failed badly because the strut thickness was significantly higher. It was around 200 micron. And from there, you know, the second generation DES is less than half of that size. And some of the intracranial stents is much, much smaller strut thickness. So what would you prefer? Do you prefer overlapping or using a long stent? We know that long stents don't do as good as short stents. But this is not because of the alteration in the flow dynamics. Even if you use a small or a long stent, it doesn't change the flow dynamics very much. But we know long stents means more neoatherosclerosis, neointimal hyperplasia, and that's because the underlying lesion is itself worse. But if you overlap a stent, there's a significant higher risk of in-stent restenosis, and this is the reason. So this is an artery here. You've deployed the distal stent first. Now you're overlapping the proximal stent. So what happens here? There is narrowing in the proximal stent, and therefore there's a high shear stress area. And in the distal area, there's a low shear stress. So in the proximal area, there's a high thrombosis risk, and then in the distal area, there's NIH, neointernal hyperplasia and neoatherosclerosis risk. Coming on to other expanded and malopposed stent. Whenever a stent is well opposed, what you see is beyond the strut, a low shear area. But if the strut is not opposed or underexpanded, what you see here is a very high shear area, very high flow velocity jet. And this high velocity jet, what it does is activates the platelets, platelets aggregate, and there's a risk of thrombosis. An example, a complication that we've seen in the past, this is a patient who had intracranial atherosclerosis disease with right-sided weakness and aphasia. There's more than 10 mm with some thrombus noted, microcatheter across, post-angioplasty with a 2 mm stent. This is good antegrade flow you see here, but then at 48 hours, patient had worsened and there is a stent occlusion. And the main reason I think in this particular instance was stent under expansion. And this is one of the problems with self-expanding stents. You do a good angioplasty, but you never know how much the radial force is and how well they're going to be. But the primary reason I think is the stent, the lesion length is more than 10 millimeter. We know from current studies that the in-stent restenosis rate is nearly 50% in the subset of patients. So why not overexpand the stent? Even overexpanded stents are not good. And the reason for this is this. If you see, these are the crowns of the stent. And when you overexpand the stent, the crown angle increases. The cell areas increases, so the plaque can protrude between the cells. The stiffness of the strut increases. It tends to fracture. And in fact, the wall shear stress drops, again promoting neointernal hyperplasia and neoatherosclerosis. What about bifurcation stenting? So again, this is from coronary literature. One may think that if there is a disease of the main artery as well as the side branch, one would want to stent the main branch and do a balloon angioplasty of the side branch. However, these patients didn't do well. So whenever you did a main artery stenting and a side branch plasty, the shear stress dropped significantly, and these patients had much more atherosclerosis, neoatherosclerosis, as compared to just stenting the main branch and leaving the side branch alone, in which case the shear stress didn't fall as much. An example case, the side branch was opened up, but if you see with time, neointernal hyperplasia and atherosclerosis developed, as compared to when the side branch was left occluded. Some example cases, I'm going to rush through it in the next 7 minutes. There's a 70-year-old male with recurrent posterior suppression stroke while on DAPT. This is the V4 segment tight stenosis you see. The main reason I wanted to put up this slide is leaving a waist is not good. Post initial stent deployment, if you see here, there is a waist here, and beyond the waist, you will see a low velocity flow, meaning low shear stress, then the high risk of neointernal hyperplasia. Therefore, it was expanded further, and this is a more parallel configuration which we would like to have. So how to overcome and what are the strategies you should follow? So why not go for a drug-eluting balloon followed by a self-expanding stent? For example, if you have to deploy a stent from the MCA to the ICA, there is a change in caliber. You don't want to really use a drug-eluting stent. So example case, this is a long segment supraclinoid ICA stenosis. Here we use a drug-eluting balloon. This is a Magic Touch balloon, 3 mm balloon. It's a sirolimus drug-eluting balloon. It's important to leave the balloon inflated for at least 60 seconds to allow adequate drug transfer. So there are some excipients which get transferred to the wall of the artery and release the drug at a slow pace. And this is the post-stenting, you see good antegrade flow. This way, we think that the neointimal hyperplasia that occurs early on can be stopped, and therefore later neoatherosclerosis chance is less. The next strategy is, why not use a drug-eluting stent directly? And with these drug-eluting stents, the risk of in-stent restenosis is significantly lower as compared to self-expanding stents. This is a patient with left supraclinoid long segment ICA stenosis, prominent leptomeningeal collaterals, right ACA secluded. This is the plasty followed by a drug-eluting stent deployment. And this is a good strategy to follow because drug-eluting stents means less stenosis in the longer run. You should have a distal guide catheter position. Use a coronary soft tip wire because this allows, enables you to take the stent as distally as possible. One of the important strategies I would like to discuss is once the in-stent restenosis has occurred, how to manage. So one of the two possibilities are using a drug-eluting balloon or a drug-eluting stent. If you use a plain balloon after in-stent restenosis, the restenosis risk is 50% as compared to 9% with the drug-eluting balloon. An example case, this is a patient who had posterior circulation stroke, had a self-expanding stent, but 3 months later had recurrent vertigo. And this is the Explorer CT angiography. This is the right vertebral artery, V4 segment. You see tandem stenosis. The proximal stenosis much more significant than the distal stenosis. This is the self-expanding step markers. Important point, less than 3 to 6 months, it's neointimal proliferation. Beyond 6 months, it's neoatherosclerosis. So what should be your strategy? If you've deployed the initial stent as a drug-eluting stent, then you think about an everolimus eluting, not a paclitaxel stent as your rank one option. If that is not what you're thinking, because if it's a small artery and too much metal, then you go for a drug-coated balloon. The last option would be a plain balloon. Don't go for a plain balloon. On the other hand, if the initial stent was a bare metal stent, then the first option, of course, would be a drug-coated balloon and followed by a drug-eluting stent. The last option would be a plain balloon. Of course, in the brain, you don't want, the more metal you put in, the risk of neoatherosclerosis and neointimal hyperplasia is high. So in this particular patient, what we did was we did balloon angioplasty, and then we went ahead, put a stent for the distal stenosis, followed by the proximal stenosis. And this is the final angiographic picture, which looks quite good. And we were cautious not to occlude the pica origin to prevent further problems. So what are the take-home messages? Early on in the first 6 months, neointimal proliferation is common. NIH, neointimal hyperplasia. Beyond 6 months, it is neoatherosclerosis. Always, if there is tandem lesion, treat both the lesions. If you treat one, there can be unfavorable wall shear stress, particularly high shear stress and high risk of stent thrombosis. If bare metal stent was the first was the initial stent, then go for a drug-coated balloon. The second option is drug-eluting stent. If DES was the initial stent, go for a second generation drug-eluting stent, which is everolimus based. In small arteries or diabetics, go for a drug-coated balloon. Don't go for a second stent. More metal means more problems. One other thing that has been described in literature is submaximal angioplasty for intracranial atherosclerotic lesions. But the main downside of this method is there's a high risk of restenosis at 26% or so. Example case, this is a patient who had left hemispheric stroke. If you see here, there is an inferior division occlusion, a pencil tip occlusion. There is a tight stenosis at the origin of the superior division, a bad anatomy. They had to use an Amplatz to take the Buron max up. This is the aspiration catheter here. Initial run again shows a pencil tip occlusion of the inferior division, tight stenosis of the superior division. Initially tried debulking with aspiration, didn't work. You see failure expansion of the stent using the Solumbra technique. There's antegrade flow, but again, debulking didn't work. The persistent occlusion, therefore, balloon angioplasty with a 1.5 mm coronary balloon was performed. You undersized angioplasty by 25% or so. And there was good antegrade flow, and we're quite happy. But one of the problems is whenever there is a negatively remodeled artery, an aggressive angioplasty potentially cause subarachnoid hemorrhage. However, we were quite clear about this, and therefore we did a undersized angioplasty and a very slow angioplasty, and despite this, you see this. So we carefully reviewed the angiography. The wire was under vision all times. There was no extravasation. The key steps to follow are drop the systolic blood pressure immediately by 20%. Because GP2B3 antagonist was given, you would transfuse 5 units of platelets, and you repeat CT. We repeated CT at 30 minutes and at 6 hours. And we did a DSA after 6 hours to check for patency. The repeat CT did not show increase in volume. The same day after 6 hours, there's good patency of the artery, and we're quite happy. But what happens after 6 months? If you see here, this is a CT angiography after 6 months. The inferior division is filling up, but there's a significant restenosis. However, this patient had cervical cancer and therefore didn't opt for any management at this point of time. So certainly submaximal angioplasty, there's a risk of restenosis in the subset of patients. Some of the complications or medical things that you need to keep in mind, this is severe supraclinoid ICS stenosis. The right IC is occluded. There's ECA collateral, prominent leptomeningeal collaterals. Balloon angioplasty followed by self-expanding stent here. Good antegrade flow. But then what you see here is this is the pre-stenting transcranial Doppler, which shows a mean flow of 57, PI of 0.8. Post-stenting, the mean flow jumps to 124, more than 100% increase despite ICU monitoring, BP monitoring. Already we had dropped the blood pressure by 10 to 20%. But despite this increase means then we have to further drop the blood pressure, and we constantly monitor with TCD twice a day, and you see that the mean has been dropped to 76 by further aggressive blood pressure drop. So hypoperfusion is a real risk, and therefore be very careful. Last 3 cases of acute stenting, just as a review of what techniques we are using. There's a patient who came in comatose. There was a vertebral artery stenosis, vertebral artery stenosis as well as distal basilar occlusion. This is after the initial aspiration catheter aspirating the clot out. If you see here, there's stenosis, there's clot here, the basilar top is occluded. We do a balloon angioplasty. We gave GP2B3 antagonist, or the distal clot also resolved, followed by stenting. And this is the patient the following morning. Another case, 75-year-old male presented with reduced level of consciousness. There is brainstem infarct. There's a basilar, mid-basilar occlusion. The basilar top is filling from collaterals. The family was keen to go ahead with treatment. Again, neuron max on the right, cervical vertebral artery. There's the aspiration catheter right up to the V4 segment here. It is better to cross with a loop of the microwire, and we know a loop will cause less injury as compared to a tip, as per physics laws. And this is the stent retriever that has been deployed from the basilar top, and you see there is long segment intracranial atherosclerotic disease. GP2B3 antagonist was given, and then it was retrieved. It remained patent, observed for 50 minutes, and remained stable, and nothing else had to be done, and the patient did recover. Another patient with right ICAD with occlusion, ACOM collaterals, but not great. We went for a full-on approach. This is the balloon gag catheter, balloon inflated aspiration catheter up to the side of the occlusion, stent retriever across. There's a tight stenosis here, balloon angioplasty performed, and good antegrade flow. So the main things I wanted to communicate by the talk are to remember what is the risk of side branch occlusion. The main problem is the threatened morphology, where there is osteal involvement and the stenosis is more than 50%. The second thing to remember is the risk of in-stent restenosis. One of the main determinants is the lesion length. If the lesion or the ICAD length is less than 5 mm, the risk of ISR is anyway low. When it goes to 5 to 10 mm, it's more. But beyond 10 mm, the risk of in-stent restenosis is more than 50%, significantly higher. We know as you reduce the thickness of your strut, the in-stent restenosis rate goes down. The bioresorbable stent had much higher strut thickness, and therefore the risk of later problems, ISR and stent thrombosis. The second generation DES is much better. If you have to put a self-expanding stent, think about using a drug-eluting balloon before going for a self-expanding stent. And wherever possible, use a DES if it is safe to do. Anterior circulation is less forgiving, particularly the MCA. When you do aggressive angioplasty, that can result in cause subarachnoid hemorrhage. Self-expanding stents, always there is a risk of under-expansion stent thrombosis. Bear in mind, you need to do an optimal angioplastic before putting the stent. If there is an in-stent restenosis, how to manage? One is, if there is a bare metal stent as the first stent, then think about a drug-coated balloon. The first stent as a drug-eluting stent, go for a second generation DES. Thank you very much for patiently listening. Thank you.
Thank you, sir. Thank you for leading us through the first topic so wonderfully, and it was really very informative. I would request our audience doctors kindly put in your questions in the chat box, and we shall take them after the second talk as well. So I would now request Dr. Vipul Gupta, sir, to kindly lead us to the next topic, which is on aneurysm and parent vessel configuration and its management as well. Over to you, sir. Dr. Vipul, sir, you're currently...
Yeah, I'm there.
Yes.
Yes. I didn't. So that was a nice talk. I enjoyed Dr. Raj Nivas. So the topic given to me is parent vessel, configuration and how we are using devices to treat these complex aneurysms. So of course, most of you will know about flow diverters and how we place these flow diverters, which are made of very thin mesh like this, reduces the flow in the aneurysm, causes thrombosis, and then later on fibrosis, and the intima grows. So to cause complete healing, except for where the branches are arising. But the challenge comes in when the parent vessel is not normal. And in those cases, to prevent complication as well as to achieve adequate occlusion, we have to get the configuration right. Like this patient is one of my very old patients when I was in Medanta, partially thrombosed aneurysm. You can see how kinked the parent vessel is. And this is not the normal course. The whole vessel, because of the aneurysm growth, has become kinked here. And this is partial coiling and the pipeline placement. And you see during pipeline placement itself, we have to manipulate a lot, but you can see the whole the parent vessel has changed here. This post looks very different anatomy as compared to the pre, and a lot of stasis. But look at the follow-up. Now we have a normal looking vessel. So if we hadn't done that kind of manipulation to open up and get the opposition right and the vessel remodeling, we wouldn't have got these results. And this is particularly important in posterior circulation, like fusiform aneurysms. If we don't get a proper parent vessel, configuration of the flow diverters, then of course we know the complication rate will be high and very useful in this case. This is a long surpass we placed. I usually like to place a single long flow diverter rather than overlapping ones because they can have more complications. And this is the vaso-CT, which we always perform in anterior circulation as well as posterior circulation, and where you could see it's a perfectly opposed flow diverter. All these small vessels are pretty well open, and this is the follow-up shows a good outcome. So what are the other conditions where diseased parent vessel is there? And particularly it is important in acutely ruptured aneurysm like blister aneurysm, where the parent vessel is damaged. It's not a Barry aneurysm, and we have a lot of experience in using particularly pipeline device in these situations and other flow diverters as well. So this is a classical location of blister aneurysm, and in this case, if you don't get a great opposition and remodeling in this area, what we have seen, then the long-term results may not be so good. And particularly nowadays, we are doing most of our cases using pipeline shield technology, in which it is coated with synthetic phosphorylcholine, which is less thrombogenic. That means when we place EVDs in them, and suppose EVD has to be placed, then they require less antiplatelets. Also, at the point of time, we follow a routine antiplatelet regimen. But yes, if need be, it is probably safer to have them on single antiplatelet than other flow diverters. So this is what we did in this patient. You can see this is the pipeline device. And again, you can see we have done a lot of packing in this area to get perfect wall opposition and to get proper flow diversion. And this is the follow-up, which shows a good configuration and where the aneurysm is completely healed. There is some intimal hyperplasia, but doesn't matter. There was a very good anterior communicating artery. Another case of blister dissecting aneurysm in acutely ruptured aneurysm. Here, what you see, parent vessel looks pretty diseased. There's some narrowings there. If you place a flow diverter here just in the center, not only it will not work well, but it will occlude as well. And this is the true neck of the aneurysm. This is how the parent vessel is supposed to be. And this is how we managed to place our flow diverter here. Again, a lot of packing done in that area. And you can see it has remodeled the parent vessel pretty well. So many situations, you can just use the flow diverter and its radial strength with manipulation to get this proper parent vessel configuration. Particular dilemma comes in cases like this. This is a patient with a ruptured posterior circulation right vertebral artery dissecting aneurysm. Our usual, when there's a good left vertebral, our usual approach would be just occlude the parent vessel. But here there was a problem because what you can see, there's clearly a large perforator arising directly from the aneurysmal segment. This is particularly common when the pica is not arising from the vertebral artery in this segment, then the perforator arises. So it's very difficult here to occlude the parent vessel without having some risk of ischemia. What you can see here, the artery is pretty narrowed. Maybe this is the flap of the dissection. So again, one would be worried how to open the flow diverter here. And as I mentioned, one of the things which is important is take the guiding up as much as possible so you can apply proper force, and generally usually we like to use flow diverters with good radial strength. If not so, then be prepared to do an angioplasty to get the proper configuration. So again, you can see once our catheters are crossed, how the whole artery, small artery is crumpled up. It doesn't matter. As long as you're finishing here, don't place it in this segment. And this is the flow diverter being placed. We managed to finish it right here. Here you can see how good now it looks. The whole artery configuration has changed completely. The flap is now well opposed, and when you draw the microcatheter, the artery takes its normal shape, and you can see good flow diversion with stasis all around. And this is the follow-up of the same patient. When you get proper wall opposition, then what we have seen with single flow diverters, you get very good results. You can see perfectly reconstructed artery, and you can see the perforator is well preserved as well. And one can see very nice layer of intima which is covered. And then you know, even if you stop antiplatelets or put them on a single plate, is safe. If the flow diverter is not opposed to the wall and endothelium is not covering it, then patient probably needs long-term antiplatelets, and you don't know when in any clinical situation you stop those drugs, then what will happen. Sometimes it's very difficult, like this cavernous aneurysm with a significant stenosis here. So we did some angioplasty before, but whatever we may try, the flow diverter didn't open them in that area. And the only choice in this case, if you leave it like this, you're looking at a complication. So we went in and placed a coronary stent within. This is extreme situation. It's very rare. We have only done one case like this, but then one has to prepare for something like this. And this is the final configuration which achieved, and patient did pretty well. The second part, which I was to talk about, was distal locations as well. Now, most of you have seen nowadays, it's not so tricky any longer, that this is a Fred Jr. device. This is an anterosebral artery dissecting aneurysm, fusiform. Again, you see in dissection, this is what will happen. The artery kind of gets kinked at times. And in these cases, not the only flow diverter is not enough. You want to place some coils. This is a large aneurysm. So this is a Fred Jr. device, partially deployed, so that there is still play for the microcatheter to come in, come out, and reposition. And we went ahead with the coiling and then finished the flow diverter placement. And as you can see now, go back, you can see how the artery configuration was and how it has completely remodeled now, and pretty good result. This is the anterior communicating arteries artifactual. We have done a check angiogram of 6 months with very good results. Another patient here with a fusiformal anterior cerebral artery aneurysm. This is the, you can see this is the A1, dominant A1. One anterior cerebral artery, there is an aneurysm at the origin and completely fusiform, long segment fusiform involvement. So the only solution here is a flow diverter placement. This is the 2D angiogram of the same. So in this case, we used a Derivo. This is the microcatheter placement and then the Derivo. What you can see, can you see this dark line here? So what you have to do in this segment is, don't just let it hang in middle of the aneurysm, because it will be less effective and later on it may migrate as well. We packed it very tight. Try to do it along the wall of the aneurysm. You can use a longer device and you can see how the dark line means it is very well compacted in that area. And then you can get good result like this. This is the follow-up angiogram here. You can see completely reconstructed artery. The other artery is pretty well filling. The aneurysm is partially regressed here. There is some intimal hyperplasia, but nothing much to worry. Patient has done pretty well. Distal locations, when we go even more distal, what is very convenient, which we are using nowadays, is from the ball, the Vista Baby. This is a middle cerebral artery dissecting aneurysm coiled in another place, but it is still growing. You can see again the crooked artery. So it is very easy to go over a 17 microcatheter and the Vista Baby being deployed. And soon after deployment, you see the artery looks much better now. Aneurysm is almost completely gone immediately. And we always do a vaso-CT in these cases, how it looks, and looks pretty nice. So we have seen, and the same Vista Baby nowadays we have used in a couple of cases for contralateral approach. Now, what about this? This is a large pica, acutely ruptured with the dissecting, the small pseudoaneurysm here. And not only the flow diverter here is tricky, but the problem is, look at the angle of the pica here. But it's very convenient nowadays because we are delivering through the soft 17 catheters, the coiling microcatheters we are using. So we went through the opposite vertebral, went across the junction of the both vertebrals, came back into this, and then this is much better angle to enter this pica and to place the flow diverter. And this is what we did. we managed to place it here. Pretty easy to do actually. And you can see immediate stasis within the aneurysm as well, and patient made recovery. This was a very interesting, was a child with a large IC aneurysm which had ruptured. At that time, some coils were placed and parent vessel occlusion was done. Sadly, the bifurcation was involved and the aneurysm started to grow on the follow-up. Now we are badly stuck in this patient, what to do. So what we did was we went through the opposite side, and this is the aneurysm we have profiled now. And this was the anterior communication artery which was fenestrated. So we placed 117 catheter into middle cerebral artery to the opposite side through a contralateral route and a coiling microcatheter. And then we deployed the Vista Baby again through the bifurcation, soft device, easy to take through anterior communicating artery across the bifurcation, and we got immediate complete occlusion. We have done a follow-up MRI. The edema is already less in this patient. As I said, I usually like to avoid overlapping flow diverters, but sometimes one has to do it. Like this patient with the dissecting middle cerebral artery aneurysm. It was unruptured, but on follow-up, it developed this lobule. Then we decided to treat it. And in this case, we placed 2 overlapping pipelines, but it's very important to get good anchorage first and have a significant area of overlap. And you see, we have tried as much as to try to touch the walls of the artery so that it remains a very stable segment. And immediately we saw a decrease in the flow in this lobule. This was done just before the lockdown, so they haven't come back for a follow-up. But on telephonic follow-up, they're doing pretty well. Configuration, sometimes parent vessel may be normal, but your flow diverter may be not. Like this case, post-traumatic pseudoaneurysm, we place a flow diverter, looks perfect. We always do vaso-CT, and now you can see there is a gap here. So it's very important to use this vaso-CT technology. And what we did was ballooning of this flow diverter and then a repeat vaso-CT. And here you can see now it is well approached. And now, as I said, more effective and less complications and easier to stop antiplatelets later on. Now, coming from flow diverters to microstents, which we usually use not in distal arteries or bifurcations. Of course, we use both Baby Leo, Elvis, and Neuroform Atlas. So I'll go through some various techniques for parent vessel configuration. Like this aneurysm is a middle cerebral artery aneurysm. She had history of headache, but you can see there is a lobule here. So you want to treat this aneurysm. Now, what about this area? There's an artery arising from here. So where is the parent artery here? So you must think this is the parent artery, but no, we think this is how it has to be, and this is how we will remodel our stent, and by shelving technique. So this is the microcatheter placement, the stent deployment. Here you can see it's not really protecting this artery, and then we compact it, what we call a shelving, overexpand it. So it takes the shape which we wanted it, and then it's pretty easy to go ahead and coil it completely. Sometimes when you can't use this and can't cover stent to cover the branches completely, then rather than placing 2 stents, we can use stent and a balloon here. Like this patient, unruptured but ugly looking aneurysm in this patient, you can see, and it's pretty difficult to get this near the neck lobule, even with the modern devices of intra-aneurysmal devices we'll be discussing further. So this is the 2D images of the same, and what we have seen is we place the stent as well as a balloon catheter, and then we are doing the coiling to get the right configuration, and then you deflate the balloon to see it's stable, and then you reposition the microcatheter into the upper lobule and got that also properly occluded, and then you remove the balloon and deploy this. So sometimes one can use this kind of technique to avoid using 2 stents in these patients. Just a case which we did 2 days before, and look at this complete dysplasia of the middle cerebral artery here. This is the bifurcated, the upper division is completely involved. What you can see is a very flattened aneurysm and 2 lobules projecting up and down, and this is the end hole view. And it was difficult to get complete occlusion because your microcatheter get trapped in this or this part. After stent placement, then you may not be able to push the coils to the other part. So sometimes you have to be ready to use multiple catheters here. So what we have done is, this is the stent microcatheter, and we have placed 2 coiling microcatheters. One was directed inferiorly and one was reverse shaped to direct it superiorly. And then we placed 2 coils first before deploying the stent completely, partial deployment of the stent and 2 coils, and then we deployed and expanded and pushed the coils in. So sometimes you can use, when the parent vessel is involved this way, one can use this technique of using 2 microcatheters and partial deployment of stent, and then you see with 1 microcatheter we coil the lower part and other microcatheter we coil the upper part. Here you can see how reverse shape it is directed in this picture pretty well. and you get pretty adequate occlusion in the end. There is some partial filling in this area, but we are pretty hopeful because on the angiogram there was complete stasis here that this will thrombose as well. It looks pretty well occluded. And this is how it looks like on the CT scan. You can see the stent, and you could get coiling all around using the 2 microcatheter technique. Sometimes when it's very distal vessel, even a stent works like a flow diverter. This patient had a dissecting aneurysm, ruptured aneurysm, and this is a motor cortex artery. We can't occlude it. You can see how again the crooked artery is. This is the pseudoaneurysm. At acute stage, it was coiled. You can see the stenosis here in the vessel, stenosis here as well. Sadly, on the follow-up, it started growing again. So we went in, we placed a few more coils and then placed a stent. But how do you get a stent to that distal location? You have to get the distal access first. Here, the 5F Navion was taken right, almost up to the M2 over a 3/8 catheter. And then we coiled it a bit, and then you're deploying a baby Leo. So only way to get it expanded in that distal location to have a very distal access. And this is the stent being deployed. And in the end, you can see it's a well open stent. We have completely remodeled the artery. Even then, it doesn't look great. There is some filling here, but see how the artery gets remodeled on follow-up. It's completely, because the key was to use the distal guiding to get complete open, so we can apply enough force to open the stent in that stenosed artery, and then if the stent is open, then on long term the result will be pretty good. This is middle cerebral artery ruptured dissecting aneurysm. There is some narrowing here. You can see here as well. This is acutely ruptured, so we placed overlapping stents in this patient. So this is the first stent placed with the trapped coiling microcatheter, the second stent overlapping, and the third stent overlapping. And then we coiled this part of the aneurysm and repositioned to coil this part of the aneurysm. And in the end, looked good, but you can see there's stenosis and there's still slow flow in the middle cerebral artery. We did angioplasty of the stent. So you have to be ready in these kind of situations. This tricky case is to you do angioplasty, and then this is the 2-year follow-up. It looks very good in this patient. The last part of my talk is about the intra-aneurysmal devices, particularly for bifurcation aneurysm. And I think they are a huge advance, and particularly they make some broad neck aneurysm treatment very convenient, and I really love it. Very fast, low radiation exposure, very quick procedure. The issue remaining is cost, and we have to gain a lot of experience with these devices. This is the Webb device, which is like intra-aneurysmal. You can see this like a ball of metal, fine mesh intra-aneurysmal flow diverter, and you can deploy through a microcatheter and then detach it. This is one of the cases we've done with my colleague Dr. Manish Chuk at Gangaram Hospital. So we have placed the microcatheter. It was a ruptured aneurysm. You're deploying the Webb, and you can see here, once you are sure it is well positioned, you could just detach it, immediate stasis, and a complete occlusion as well. This kind of aneurysm would have got 2 balloons, stent in a balloon, or 2 stents, and this procedure done in 20 minutes. So it's really wonderful to use these devices. Another device which we have used is the contour device, which is different, which is like a cup, which opens at the neck of the aneurysm. And it is pretty easy to use in many situations, although we are still getting more experience with it. This is one of the tricky cases we have done with it, basilar top ruptured aneurysm. And how to get a neck configuration here. There's a severe stenosis in the upper basilar. She was an old 84-year-old lady. You don't want to place stents in these patients in ruptured state with stenosis, spare vessel stenosis. So this is what we've done. We coiled it partially, and now the contour is being deployed. And the contour is being deployed, and this is the immediate follow-up. The contour is somewhere here. I will show you the VASO-CT images, but what you can see, immediate complete stasis here, and this is the contour device. And we always do a VASO-CT, and look, in this view, it looks as if it's hanging in here, but here in this angle, you can see another angle is well opposed to the wall, so it remains stable, and patient did pretty well. Another patient, middle cerebral artery aneurysm, which would have been very challenging otherwise, maybe a stent and a balloon or 2 stents. And I was pretty curious to see what will happen is near the neck lobules in this patient. This is the 2D angiogram in 2 views. We went and placed the contour. There is immediate stasis in the aneurysm. And this is the VASO-CT. So VASO-CT is very wonderful to realize what's really happening. So see how the contour device is. You may think that there is some narrowing here, but usually this tip projecting doesn't really cause any harm, and you can do thin section. And in thin section, what you could really see, the parent vessel is paired. And in this angle also see this is the parent vessel origin. It is paired all around, and patient did pretty well. So I just want to end my talk by saying how in flow diverters, using parent vessel anatomy, understanding parent vessel anatomy, how disease it is, how you want to remodel it, and sometimes you just use the device, sometimes you do angioplasty, sometimes really you may have to do a stent, and distal access is how it is important. Proper choice of device is pretty important in these cases to get this remodeling right. And how even with micro stents there is a lot of play. It's not just stent and coil. How again distal access, getting them open, over expanding them at times, or at times deploying coils, under deploying the stent and using 2 microneedle placed coils, or having overlapping device with angioplasty. All those can help. And the last part, of course, was about the bifurcation devices. I'm pretty sure they are going to get better with time, and I'm pretty sure that we would love to use them more and more with time. Thank you.
Thank you to both our experts for those wonderful insights, and I'm sure we'll have many meaningful queries on the topic from our audience doctors. I have shared it in the chat box, but sir, would you like me to read them out one by one?
I think Dr. Raj can see there is first question is, I can ask Dr. Raj, any role of thrombolytic agents in management of large vessel occlusion? I don't know whether they mean IV or intraarterial.
So yes, of course, for large vessel occlusions, we know that if there is a distal M1 occlusion, nearly 40% of them will open up with thrombolysis. And if there is a mid to proximal M1, 25% are going to open up. So yes, there is a definite role for thrombolysis in large vessel occlusions. So even if at the current moment in time, there is no evidence to suggest that you can go for direct thrombectomy. Still, evidence needs to be in place to consider that. Because in India, thrombectomy centers are less, we still should follow as thrombolysis, and wherever possible, bridging should be considered. And patients can be thrombolized in a peripheral center and shifted to a thrombectomy center. That's also an option.
I think the next question is, do you recommend alteplase in patients with acute ischemic stroke of 4.5 to 9 hours duration selected with plain CT?
No, because at 4.5 hours, it's beyond the recommendation. As you know that the number needed to treat between 3 and 4.5 hours itself is 14. So at the current moment in time, there is not enough evidence to suggest that you can use between 4.5 to 9 hours.
All right. And what are the medical legal aspects of prescribing alteplase in OPD? I mean, even I don't really understand the question, because you never prescribe it in OPD. It's an emergent use of drug. I think you agree, Raj, right?
Yeah.
So I don't think one can. Yes, what is true is that maybe at periphery, even general physicians can get trained in use of AV thrombolysis. Maybe if that is the meaning, yes, after training, even in peripheral centers, and it's pretty safe drug to use when indications are followed. So I think that much we can say. So when do we attend an ICAD after an acute stroke after thrombolysis? I mean, I think they're talking about acute stroke post thrombolysis. Does your protocol of managing ICAD change in any way, or drug usage change, Raj, if you have done thrombolysis as well? Yeah.
Yes, sir. I think if you're suspecting ICAD as the primary etiology, then thrombolysis is very less likely to be helpful, because majority of it is the plaque and there is a surface thrombus. So in these set of patients, we would go for a simple angioplasty, a submaximal angioplasty with GP2B3 antagonist. If it doesn't work, then we go for stenting. So thrombolytic drugs along with GP2B3 antagonists significantly increase the risk of bleed. Of course, if you're in a peripheral center, you don't have access to a thrombectomy straight away, then you should go for thrombolysis and then shift to a thrombectomy center.
All right. There's another question, role of COVID in increased incidence of LVO. I mean, have you really seen it?
No, so even in the papers from the West, they've not really shown an increase in the number of strokes in the COVID period. So we have not seen at our center even in April, May. But of course, majority of the patients had severe lung disease. So maybe these patients never got recognized also. So it is very difficult to say. There's no literature to support that there is higher risk of stroke in this subset of patients.
All right. So there is one about to prevent perforator occlusion, minimum porosity requirements. So there are a lot of studies done initially which studied the porosity, how much you need it. And usually we know when it's 30 to 35% metal covered area, that is what we achieve with flow diverters. So I don't remember the exact figures, frankly. So when you're using properly sized flow diverter in an area and you're not compacting it too much across the perforators, then chances of occlusion are pretty low. What we do in cases of basilar artery particularly is which is prone to perforator occlusions is we oversize the flow diverter a little bit. So that will reduce the metal coverage and prevent perforator occlusions. So there is one question: do you overlap the stent mainly for addressing stenosis or any other reason? So I don't know whether it's directed to ischemic or the flow diverters. So in flow diverters, of course, on stents we only overlap when the aneurysmal segment is very long, and the only way is to overlap the device. Otherwise, I would use a single long device. And I don't think we showed any ischemic stroke where we overlapped, except for one case where patient had a re-stenosis after self-expanding stent, and we placed balloon expanding drug-eluting stents within because that was the only solution which was there. Is there any role for IA tirofiban in distal branch occlusions? So
if it is an
ischemia, and it can be both in ischemia and aneurysm treatment, you can cause complications. In those, definitely we use antiplatelet agents, whether Riopro, tirofiban, for them. And if you see in acute stroke branch and peripheral artery, peripheral distal branch occlusion, what would you do? IA tirofiban?
Tirofiban will only work for an acute platelet clot. It is not going to work for a preformed clot. So yes, if you suspect that it's a pure red clot, then it might work. But generally, in those cases, we go for intraarterial TPA if there is a distal branch occlusion.
Yeah. And the last question I can see is it safer to use single interplated with shield rather than use other stents? So shield technology has been shown in vitro to be less thrombogenic. And there's a paper from Australia in which they did with single antiplatelet. Initially, they had complication, but they managed for a few weeks on single antiplatelets. But a different protocol, they use a BD dose of aspirin, low dose of 300, and it was all right. In our cases, we still use double antiplatelets. What we have done is many patients with gastric issues, we don't use aspirin. Then we have usually do only on Pasugrel and Ticagrelor. But at this point of time, we haven't done any case only on aspirin. The only advantage is when we have used the flow diverter and by any chance you need EVD to be done, then it's comfortable and safer to stop the second antiplatelet for a few days with shield than maybe with other stents. But clearly we need long-term studies and randomized data to be sure how to use the antiplatelet agents with shield. Yeah.
So I think that's it from the audience question side. So any final thoughts from both yourself and Dr. Parthasarathy's end? Or I think we'll take it ahead and close the session.
No, I think it was a pleasure and I enjoyed it. I hope others enjoyed it. We haven't interacted with them directly, so I don't know who all are there. But thanks. I mean, I know after 1.5 years, attending an online talk takes something, So all of you who attended, I really want to thank you for the time you have given to us.
Thank you, sir. And a big thank you to both our panelists, Dr. Vipul Gupta sir and Dr. Raj Srinivas Parthasarathy sir, for such an enterprising and interesting talk and taking us through the entire session. I am sure this will definitely help us align our clinical practice with the valuable insights that have been shared today. I hope all of us have found it to be a valuable experience. Thank you all for sharing your time with us. And thank you once again, sir, for a memorable evening. This is me, Dr. Kumar Deep. We are signing off from today's webcast. Take care and stay safe, everyone. Thank you.
Thank you.
Thank you.